Hi, everybody. I'm gonna this week or this month we're gonna be talking on our GLP-1 weight loss program for about the new formulation and also about what effects weight loss has on women with lipedema. So that's the topic for tonight, and we'll be able to just jump right in and give a little presentation recording. So let me background. GLP-1s are very effective at weight loss, and there's many brand and formulations with using these GLP-1 peptides to for weight loss. And one of the any kind of weight loss, whether it's bariatric surgery or diet, just regular diet, low calorie diet or ketogenic diet, anything that leads to weight loss, um, including the GLPs, leads to muscle mass loss. Now, and generally, about 20% of your weight losing on any of these things is 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 muscle mass loss. So 1 out of every 5 pounds is lean body mass, and that's how we speak of it more scientifically. Um, and 4 out of 5 would be fat loss or adipose tissue loss. Now, glycine is an amino acid, essential amino acid for building proteins, and it has blunts the muscle mass loss. So our new formulations have glycine in them, which um, will help reduce muscle mass loss while losing weight. Additionally, I've talked before about their studies showing that even just adding some resistance, and I'm going to tell you the study that looked at these. There were three simple resistance exercises. There were push-ups, squats, and sit-ups, and they had patients or participants um, you do those every day while they were on the weight loss program, and they so when they did the exercises, the push-ups, sit-ups, and squats, they also diminished the amount of weight of muscle mass loss that, as I explained, always goes with weight loss. So they decrease the amount of weight lost from 20% or one to less than 5%. Um, that's a quarter again. So really, 90 to 95% of their weight loss was in the fat mass by doing those exercises. And we think that we're not sure exactly how much more muscle mass you're going to preserve with the glycine, but it will help as well. So our new formulations for tirzepatide and semaglutide are now have the glycine added. And I'm happy to answer questions, or I'm going to move on. Um, so now I'm going to talk about weight loss and metabolism and lipedema and also body composition. So this is the result of some research I've done in collaboration with the Washington University and St. Louis University Schools of Medicine. And and then it was supported by the Lipedema Foundation. And what we looked at in these studies, this was just using diet. This is using a modified Mediterranean diet, low calorie diet that was provided. So initially, it was provided as pre-planned out or pre-cooked meals, and then eventually it was just pre-planned out meals for each of the participants in the subject in the study. And they underwent like very elaborate diagnostic workups. I mean, they were diagnosed by with lipedema by me, but then they had MRIs and DEXA scans to assess their body composition. They had glucose, a very sophisticated way to measure glucose metabolism, specifically an insulinemic, hyperinsulinemic glucose clamp. And what that allows is to see specifically the most accurate way to gauge insulin sensitivity. So, and they also, I'm going to go a little more, and also we looked at the tissue in the thigh and abdomen and all sorts of other things. Looked at genetic expression in the tissue. We looked at all sorts of other metabolic parameters, including an MRI of their liver. But so it was a very, I mean, really probably one of the most thorough ever studies of lipedema. Now, backing up a little bit, so I believe in treating lipedema comprehensively. And so diet and so this really focuses on the diet that's low in refined carbohydrates, but it should be part of a comprehensive treatment of lipedema that should include compression, regular exercise, possibly GLP-1 supplements, medications, possibly a pneumatic pump, possibly MLD, and possibly surgery. So those are all the what I consider part of a comprehensive management, but everybody should be wearing compression. Everybody should be on some type of diet. That's those are and trying to be as active as possible. So now, so this is just a little bit about the surgery. This is really for people that are still having symptoms after they've done some of the conservative or all of the conservative treatments and still are symptomatic. And it can improve. So I've published papers showing that it can improve pain, mobility, quality of life. And these measurements, that these mobility improvements are specifically linked to longer lifespan and decreased risk of disability. So these are powerful things, and I also was able to use the same measurements they use for like knee replacement, and these measurements, the mobility gains, the pain gain improvements, were comparable or better to what a total knee replacement. Okay. So first, one of the questions I answered in this research that I'm speaking to you about was, is lipedema disproportionate? I mean, we've always talked as though it is a disproportionate accumulation of adipose tissue, but this is the first time we've had actual DEXA scans and MRIs to prove it is adipose tissue that is accumulated in the legs, in excess. So, and I'm going to go into that data, but that was one of the important questions. Really, is that the basic of lipedema? And yes, the legs of women with lipedema were 23%. Had greater leg fat mass compared to BMI, age, and sex match controls. So, so that kind of both proves that what we're diagnosing is lipedema, and also that lipedema does have that. So it's it kind of corroborates the diagnosis, as well as gives a numerical percentage that we see. So now, as I explained, this is a weight loss study, and so can the fat in a lipedema affected leg decrease with weight loss, because that's all been a constant saying that it can't be lost. But we did see that they're with about a 10% weight loss, they lost about 10% of their leg fat mass. Um, and that's so this is comparing the blue are BMI matched controls, and um, I'm sorry, the blue is the lipedema, and the orange are the BMI matched controls. And they so both BMI matched controls and lipedema ladies were able to lose leg fat mass with weight loss. However, the percentage of leg fat mass did not change in the lipedema subjects. And so, yeah, so they still, the greater percent, this 23 um, percent increase in leg fat mass persisted, even though they got smaller. So how is the metabolism different? Because we hear often about women who say um, their metabolism is different than people without lymphedema, and they're right. So um, women with lipedema are more insulin sensitive. So they're 48% more sensitive compared to BMI matched controls. That p-value is wrong. It's actually p less than zero 0.05. So that's a typo. But so the um, so lipedema women um, are in gray, and they are closer in their insulin sensitivity to lean, normal BMI women, and just women who are overweight, similar BMI to the lipedema, are more insulin resistant, and by so they're 48% more sensitive, or the other is 48% more insulin
Dr.
resistance.
Wright,
Yeah.
can you explain when you're saying that a patient is insulin resistant, what that means for them in regards to their fat loss?
Yeah. Okay. So insulin sensitivity is so normal, is associated with health. And insulin resistance is associated with diabetes, heart disease, high blood pressure, all sorts of complications. So, in a way, the lipedema disease protects against some of those insulin resistant diseases. Um, However, that also means if you're relatively more efficient, insulin efficient, that means you're able to also deposit calories in via under so glucose and other carbohydrates are more efficiently
You want to bring your
deposited.
bags up there? You good?
I'm sorry, I didn't. Okay, I'm just going to continue. So it what we found further is with the weight loss, um, the women with lipedema, the insulin sensitivity improved. It actually became close to normal, even though their BMI was in the overweight range. So um, yep. And then so we also looked at tissue samples from the thigh, and we also used the abdomen as control. But what we found in those tissue samples was that the endothelial cell differentiation, endothelial cell proliferation, these are markers of fibrosis, and also markers of angiogenesis and blood vessel development were upregulated. So this is consistent with the fibrosis we see in lipedema and the increased vasculature. Um, and so fatty acid metabolism was downregulated. So both in triglycerides and also more complex lipids were downregulated, which I'm not sure that may be why they're less sensitive to um, weight loss, but it's that's not clear, but it is interesting that that fatty acid metabolism is downregulated. So what do we find out from this? So fat and lipidemia areas can be lost with a low low refined carb Mediterranean based diet. And there's no cure for lipedema, so diet really should be part of everybody's treatment of lipedema, the clean, low refined carb diet. Treating lipedema solely as a surgical disease is inappropriate, and surgeons should ensure that their patients are following conservative measures before embarking on surgery. Okay, that's it. Thank you for your attention. I will answer questions now.
So for the ladies who are doing the GLP-1s, and they're, you know, the GLP-1s are tricking your brain into thinking that you're fuller longer, and really decreasing your appetite. So when Dr. Wright's talking about, that Mediterranean diet and those good carbs and good proteins and things like that, those are going to be essential with being on this medication, because what caloric intake you're taking in, you want to make sure is the best that you can take in for what you're gonna, be hungry for. Because I'm telling you, I've been on this medication and it really does decrease your appetite. But I know that the better I eat, the better I feel on it as well.
Is there a certain uh, amount of calories that we should be have for a daily goal while on the medication?
It's not necessarily a caloric intake. But Dr. Wright really wants you guys to hit around, close to 100 of protein, right, Dr. Wright?
I want you to make sure you get enough protein because that a lot of the side effects and muscle loss are related to low protein consumption. But you should naturally decrease. I mean, you are going to be full. That leads to calorie restriction, but um, I don't think you have to count calories. You certainly can if you want, but we don't necessarily you know. Um, advocate for that. So, um,
And Jennifer, I do have a form that I can send you that can help you figure out how many calories and how many macros and things like that you should be taking in. Um, but I will tell you that it's even hard to hit that goal when you really have no appetite. So I'm just warning you, okay?
Okay. So the protein should be the focus.
you want to, yeah, get low processed protein would be, you want to make sure you get, probably I would like to get 100, you to try and get 60 to 100 grams of protein every day.
Okay.
Uh,
And
more is okay.
more is okay. Okay. Should is the timing of the eating, if we're really not feeling hungry but making needing to make sure that I eat something, is there a window of time that I should focus on, like almost like a fasting, just or just not worry about that either?
Well, so I think you will find, I mean, people are individual people vary, but some people will get really weak and nauseated if they don't eat something. Now, if it turns out that you don't get weak and nauseated, you can eat when you want, but many people on this um, really need to ensure that they eat something, and preferably earlier in the day. Now, that's again, not everybody's like that. Some people can still wait till later in the day to eat, and if you're getting a lot of nausea or weakness or something like that, then I would want you to make sure you're getting your protein early in the day.
Okay.
I will tell you, Jennifer, that, I have some patients that kind of have to eat something, every, 2 to 4 hours or whatever, just because, if they're having some nausea or indigestion, it helps them with that, is actually to eat something to help with it. But then I have other patients who find it much easier to do the fasting method because they're not feeling as hungry. And I have found that to be true for me. Like fasting was very difficult for me in the past,
Hmm.
but being on this medication, I really don't even think about eating till noon or after. And then what I'm finding with myself is that I'm getting one good meal in, and the rest of it is more protein snacking.
Okay.
Does that make sense?
Yes. And is the meal what you're usually having as your first part of food?
No, it's usually like my dinner portion is where I'm getting my big meal in. But if I did get my meal in for like lunchtime, I'm not even hungry for dinner.
Gotcha. And should we just try to completely eliminate carbs, or, I mean, in vegetables, I'm assuming we should still have some in the form of,
Yeah, I think, for me, I think the best diet it still includes complex carbohydrates like vegetables and and some fruits, whole fruits and vegetables, not certainly not fruit juices, which are really just sugar and but complex um and
I've been doing good with like brown rices and sourdough breads.
okay.
So
Um,
if you're gonna have a little sourdough bread, or obviously in moderation, or that, so I think it's best if you make sure you have a little bit of balsamic vinaigrette or something like that to that'll inhibit the maltose, which makes the digestion of it um, more slowly. And also olive oil, and olive oil is good for you, and so is balsamic vinaigrette. And or you don't have to do that, but I mean, it certainly is a trick that will make it even more filling and last longer.
Okay. Thank you for that. I am nervous about my first shot, but hearing the results, especially the possibility of losing, some of that fat in the leg is very encouraging.
Oh, yeah, I think it's exciting. Yeah. Um,
I have not heard from any of um my patients, and I'm dealing with all of the lipedema ladies, that they're not having those decrease in inflammation symptoms, their inflammation is definitely being decreased. And that they are being successful losing weight. Some of them, yes, much slower than others. Um, but nonetheless, they're still being successful. Really, the only people that I've had stop the program, it's been for financial reasons.
Yeah. That is understandable, but in the long term, I'm hoping this is Yeah, it is worth it to make this investment now.
Right, right. And that's what's good about this program is, it's not something that you have to sign up for, a 6-month program and you're locked in and you have to do it and you're paying for it. If we get a few months in and we feel like we're not being successful, we stop. But I haven't had anybody stop for that purpose, that they weren't being successful.
I am, well, we are a part of a study, right? You're gathering this information on us, and there, am
Yes,
I
yes.
understanding that correctly? Okay.
Yeah, we are collecting,
That's what
your
the
response.
surveys are for. And then when you're sending me your weight measurements.
Perfect. Well, that's exciting to be a part of that as well.
uh,
Oh,
Sorry.
and so you do these webinars regularly then?
We
Yeah,
do it
we've
the
been doing them
third
every.
Tuesday every month.
Okay.
And
I,
you can use the same link.
okay, that's good to know. I will be sure. I will put it on my calendar. Um, because probably I just did my order yesterday, so if we have another 7 to 10 days, so we'll be getting closer to that time.
Yeah.
Should maybe we'll have one or
Yeah,
two.
you'll probably get it by next week, and then you'll, be a good 3 weeks into it for the next webinar.
Yeah. And I work Monday through Friday in a school. As far as maybe first reactions or you know not feeling
So
great.
if you have a tendency to potentially get nauseated or have GI effects and stuff, I would honestly tell you to try it like on a Thursday night or a Friday morning into the
Okay.
weekend to see how you're doing. And then you can kind of adjust your schedule accordingly. You can keep pushing it out a day if you would rather do it on Mondays all the time. I do mine on Thursday nights, because
Okay.
I know that if I'm going to have, any kind of, nausea or anything like that, it usually happens like Saturday morning.
Okay.
But that's for me. Everybody's kind of different and stuff. So you're just going to kind of have to figure that out. But I wouldn't do it at the beginning of the week. If you're a teacher, I would do it towards the latter of the week going into the weekend.
Okay. Perfect. Well, thank you so much. I appreciate it, and I appreciate this information, and I'm going to go back and look at the past webinars now.
Yeah, good, good. If you aren't able to find it on the YouTube channel, let me know, and I can send you the link to it.
Okay, wonderful. And then do I need to let you know when I start?
No,
Oh,
no, you don't. Just a week after you do start, the day that you start, the first thing in the morning, when you wake up and you've gone